Laura, I'm the Programme Lead for the London Dementia Clinical Network. Thank you to the National Audit of Dementia team for asking me to talk this morning. So for the next 15 minutes or so, I'm just going to be talking through a bit of the history of the London Memory Service audit, how we've got to where we are today, how we completed the national audit in 2019, and some of the key findings from the national audit. Now, the audit really started with our memory service network. Back in 2014, a group of memory service clinicians in London got together to share best practice and learn from each other. And this has really developed from a small group back then, and now we have nearly 200 members of our memory service network and hold quarterly network meetings. And it was at that group they were discussing that, you know, we had quite good data on things like dementia diagnosis rates, but we didn't really know much information about the variation between memory services, and anecdotally it was felt that there was quite a bit of variation. So through that group we developed a data set using evidence base and the MSNAP standards and piloted a memory service audit. Now, the pilot showed us that an audit was definitely worthwhile because there was variation, but also quite importantly, it showed us that each service needed to audit 50 patients in order to have enough data to compare between services. So this led to our first audit in 2016, and 10 London memory services participated in that. And then we had a break and we did various regional quality improvement projects, and I'll give you a flavour about some of those shortly. And many memory services also did their own local projects. And then in 2019, we did our second London audit and 20 services participated in that one. And some of the new services told us that they really saw the benefits from participating because we did various events to showcase the results, which made them want to participate next time. I think the other key thing is the audit tool has been refined throughout the different audit cycles. So obviously we had the NICE guidelines coming out, so we updated the tool. We also had feedback from services that have told us how to make the tool easier to use, but we've kept that real core data set, so we've got really good comparable data. And obviously if the audit tool was used again, we would add some additional things like virtual consultations. So I just wanted to give you a flavour of some of the quality improvement work we've done as a region in between the audits. So first of all, the audit found that 85% of people under the age of 65 going to a memory service didn't have dementia. And services were keen to think about what would be the best pathways to follow for these patients. So we got an expert group together and looked at the evidence base, and we've pulled together this, it's a toolkit, that's a picture of our toolkit, which looks through clinical pathways for people with mild to moderate depression and anxiety, alcohol misuse, functional cognitive disorder and MCI. The audit also demonstrated variation in neuroimaging practice, and services were quite keen for some guidance on neuroimaging, particularly who might not need a scan for a diagnosis. So again, we got a group together and we've written a guidance document. We also found quite a lot of variation in post-diagnostic support. So we used that variation and the NICE guidelines to have discussions with commissioners to make sure that they are commissioning evidence-based post-diagnostic support. And finally, the audit found quite a variation in waiting times, and this was around a similar time where the national 6-week ambition was coming into place. So we did a project where we went around the memory services and mapped their pathways from referral to diagnosis and initial care and support plan. And we mapped it step by step. You can see an example of a service map there on the screen. And what we did, we learned from other services and shared best practice. And also we looked at applying lean methodology to see if there was opportunities for services to reduce or eliminate steps or combine steps together to reduce waiting time without impacting on quality of care. So these are some of the key differences we found between 2016 and 2019, and 9 London services participated in both. So as you can see, more patients were seen in clinic, waiting times had come down, more people were being offered cognitive stimulation therapy, and quite a significant difference in the proportion of patients offered a dementia advisor. Neuroimaging variation remained the same. So moving on to the national audit, when we were doing the London audit in 2019, internally as a team, we had a discussion and felt it was a bit unfair that London services got to do this and other services across the country couldn't access it. So we decided in the London team that we would put a bit of capacity together to support a national audit, but we couldn't do it on our own. So we worked with the other clinical networks across the country and asked them if they would like to participate in the audit. They then invited their local memory services to participate, and all the services did the audit of the 50 consecutively seen patients. There was then various regional analysis and events held, and then in London we pulled the data together nationally to have a national comparison of the services and look at a national picture of memory services. And I saw lots of services joining on the call who I know participated, so thank you very much for participating in the audit. For those of you who haven't seen it before, this is just the audit tool, so it's probably a bit small to see properly, but just to explain, so there was a set of organisational questions such as, are you MSNAP accredited? Do you have a name lead for young onset dementia? And then it goes through a case note audit, so it looks at the referral, so when the patient was referred, who referred the patient demographics, what took place during the assessment, so did they have neuropsychology, were they asked about falls. It goes through investigations, so whether they had a scan, what type of scan they had, whether they had specialist investigations. Then it goes through diagnosis, so type of diagnosis and when they received it. It goes through the post-diagnostic support you'd expect, CST, carer psychoeducation and care navigation, and then there's a question about consent to contact for research as well. So this is just to give you an idea of the participation in the 2019 national audit. So as Chloe said, 85 services participated, which gave us data on nearly 4,000 patients, and 5 regions of NHS England participated. So there's, you can just see a breakdown of the different areas and number of services that participated there. Just to give you a bit of an idea of the services that participated, so half were MSNAP accredited, most were part of a mental health trust, and most saw patients under the age of 65. And here are the patient demographics. So the mean age was 79 and a bit of variation between services. 7% were under the age of 65, 57% were female. 12% of patients were from a BME group, and there was quite a wide variation there between services, and 36% of patients lived alone. So coming into the more meaty findings now. So first of all, we asked some questions about joint working. And what we found was quite a number of services had no opportunity for joint working. So for neurology and geriatrics, you can see it's around 20% there. And this was even higher at 30% for neuroradiology. And when there was opportunity for joint working, it was often only ad hoc advice, which is the green part of the pie. And joint working is something we've been really interested in the London region. We did a project last year where we took a MDT meeting that was held once a month, just through it was held once a quarter through clinical goodwill, and we formalised the meeting into a monthly meeting between the memory services across an STP, cognitive neurology and neuroradiology, and they discussed any complex or younger cases. And what we actually did was we analysed the outcomes of the discussion. It was really interesting. Of the 42 cases discussed at those meetings, 21 patients, so half, the diagnosis was finalised just through multidisciplinary discussion, and in another 3 cases the diagnosis was changed. This is a model that we're really interested in looking at, how this can be rolled out more widely. Looking at service variation, so I've put up several graphs. I've not gone through the whole audit, otherwise I'd be here for hours, but just picked out kind of some of the key findings. So on this graph, each blue line represents a different memory service, and the orange line is the overall national figure. So this looks at the percentage of patients asked about their hearing, And as you can see, in some services, hardly any patients get asked about their hearing, and in other services, all patients get asked about their hearing, and we've pretty much got everything in between. And also we looked at the patients diagnosed with MCI, and 61% of patients diagnosed with MCI were asked about their hearing, which of course is important for dementia prevention. And then this graph looks at the percentage of patients who were referred for diagnostic neuropsychology. Just to explain, 2 services that participated in the audit are psychology-led, and all patients see psychologists, so I removed them from this graph. But as you can see, in some services, none of that 50 cohort saw neuropsychology, and in other services, over 25% of patients did. And I think this is where it gets interesting if you're a service at either end, to reflect on what's going on locally and discuss with other services to think why that might be. If you're at the lower end, is it because you don't have access to neuropsychology? For scanning, we asked whether the patient had a scan, or whether they previously had a scan, or if they refused a scan, whether it was contraindicated, or whether they didn't need a scan for their diagnosis. So this graph looks at the percentage of people where it was deemed that the patient didn't need a scan. And as you can see, there's quite a wide variation here. So in some services, everybody gets a scan, and then in other services, over half the patients don't have a scan. We also looked at whether the patient had a MRI or a CT scan, and the blue bar is the percentage of patients that had an MRI rather than a CT, and orange is vice versa. So again, quite a lot of variation in the type of scan a patient's receiving. And again, could this be an access or a waiting time issue, or is this just clinical preference? And interesting as a service, if you're at one extreme, to discuss that locally. Moving on to diagnosis. So one of the things we found quite a lot of variation was the use of mild cognitive impairment. So this looks at the percentage of people over the age of, 65 and over in the memory services who were diagnosed with MCI. So nationally it was 18%, but some services didn't diagnose anyone with MCI. And then there's a couple of services where it's over 40%. And again, for me, if it was my service, if I was at the higher end, I might be thinking about, well, why are we diagnosing so many people with MCI compared to other services? So excuse this absolutely crazy graph, but basically this is just looking at the variation on what dementia subtype people were diagnosed with. And if you look at it for any subtype, you see this picture of variation. So the darker blue is Alzheimer's, orange is mixed, grey is vascular, yellow is unspecified, and the lighter blue is other. And how I've ordered it is for people diagnosed with Alzheimer's or mixed dementia. And we've done this because this is where you might give anti-dementia medication. But as you can see, in some services, 50% of patients are diagnosed with Alzheimer's or mixed, and then in other services it's up to 80-90% of patients. This is quite a wide variation, and it asks the questions on whether some patients aren't accessing anti-dementia medication because they're being given a different diagnosis. I'm not sure the variation here could be explained by different geographies across the country. So again, something really interesting to look at and discuss. Waiting times, everyone's favourite topic. So we looked at the average wait from referral to diagnosis, and as you can see, again, wide variation. So some services it's 5 weeks, and then other services it's 30 weeks and over. And this is something that will be really interesting to look at since COVID, if we do some comparison. Moving on to post-diagnostic support, so we found about a quarter of services were unable to provide or refer on to psychoeducation for carers. It was similar for CST as well. But what I found particularly interesting is when you look at the services that did provide or refer on to, actually only 39% of carers received carers education. Quite a high number were deemed not appropriate, and then 16% also declined. And then when you look at different services, as you can see here, although the service said they could provide it. In some services, hardly any carers were offered the service, and in other services, way over 80% were offered the service. And we found a really similar variation with cognitive stimulation therapy, and also a similar variation in the percentage of carers that declined carers education as well. Overall, we generally found less variation and more patients received care navigation or a dementia advisor type service. So I'm sure some of you were there. In January of this year, we held an event where we brought the services together that participated in the audit to talk through the results and think about potential local, regional or national service improvement projects. So I thought it'd be useful just to reflect on some of those. So it was felt that there was a real need to create local memory service forums, similar to what we've done in London, to be able to share best practice and learn from each other. There was a recognition that we do need to improve joint working. I've talked about neurology and neuroradiology, but also geriatrics and Parkinson's clinics, for example. It was felt that we really need to decide how to ask and how to assess vision and hearing in memory services and implement those pathways. There was a recognition that a lot of services aren't able to view the brain scans that they request, and we do need to do some work to improve access to PACS, something we've been grappling with in London for a long time. Services felt we really do need to think about MCI and what we can do to reduce the variation on the percentage of people diagnosed with MCI, and a audit looking at conversion rates to dementia and MCI follow-up. You know, people thought would be a really interesting thing to do. With research, we found that only 17% of patients with dementia were consented to be contacted for research, and actually over half patients there was no discussion about research at all in their notes, and services felt that creating a consent to contact script for research would be really useful. We're all aware that we need to continue to do the work to improve waiting times. And finally, frontotemporal dementia. So of the nearly 4,000 patients that were audited, only 11 patients were diagnosed with FTD. This represented 7% of the young onset dementia cohort and 0.3% of people aged 65 and over diagnosed with dementia. So it felt there was potentially under recognition of frontotemporal dementia and memory services, and services felt some specific training and education on FTD would be really useful. So just to summarise, I think the key thing for me is that we've developed this audit since 2015, and each year we develop and we improve it, and thank you to all the services on the call that's given us some really great feedback from the last audit so we can continue to improve the tool. The national audit demonstrated variation throughout the memory service pathway, and I've just picked out some of the areas today, but pretty much every area there's wide variation. But the most important thing is that we use audit data to inform service improvement. So Chloe and the team will be sending around the slides after the event. So I've just put all the links here to the QI projects we've done and the link to the national audit, which if you've not had a look at is well worth a read, and my contact details are there. So thank you very much for listening. Happy to take any questions if there's time, and I'm staying around for the discussion later. Thanks.